All right, I've got 12:01 Eastern Standard Time. Good morning, good afternoon, good evening, depending on where you're coming from. My name is Jose Pascual. Carlos Mendoza is the PTS equivalent to me who co-organizes these sessions. I'm sorry that you can't turn your video on. We've had a lot of hacking on this conference in the past. If you absolutely want that, Kevin Miller is our organizer, and you can request that by a chat to him. Otherwise, I will have both our moderators from the PTS and AASC, Abbas Badami and Rebecca Schroll, start the session. Thank you very much, everyone, for joining.
Thank you, Dr. Pascual. Hello, everyone. I'm Abbas Badami, one of the trauma surgeons in Sunderland. And are we going with the PTS case first, or do we have an order? Yep. Okay, perfect. All right. So I think the first case that we have, our presenter, Dr. Tolonen, presenting the PTS case. He's an emergency surgeon all the way from Finland. And Dr. Tolonen, welcome. And I'll have you go ahead and share your screen and take over.
Thanks so much. And thanks for the opportunity and for the invitation to Dr. Menogotzo for asking me to give this presentation. So I'll start sharing. I took the liberty to just show a couple of slides where I come from, so that we'll all be in the same page. So can you all see the slides now?
Yes, we can.
Yes. Okay. Just take that away. All right. So my name is Matti Tolonen. I work as an emergency surgeon in Helsinki University Hospital, Finland, and also have a special interest in trauma, and spent a couple of months in LA County Hospital a couple of years ago. And just very briefly, we're kind of a big hospital from the south of Finland, where the people have centrifugated from our small country. So it's a big hospital with more than 100,000 emergency room visits every year and more than 10,000 emergency surgeries performed every year. We have 38 operating rooms and 4 hybrid ORs and one this kind of hybrid suite for emergencies where you can do everything, CT, angio, and open surgery in the same bed. And we have all the relevant specialties in the same hospital. The trauma system is differently organized compared to the Americas in Helsinki. So it's out of Middle European tradition that the ortho trauma is in charge of trauma, since most trauma is blunt, not that much penetrating every year. These are the numbers for severe trauma, ISS more than 15. And all relevant specialties have an attending in-house at all times, and we do a lot of cooperation. It's not just trauma surgeons operating on trauma, but we get invited from different specialties also. And the system is that all the unstable patients go straight to the Raptor OR. So here's the case: a young 18-year-old female at time point 0 minutes, which was 10 p.m. I got a call from EMS that she had been stabbed, a single epigastric stab wound. The EMS was on place 8 minutes after the call, and she was heavily unstable with cold peripheria, cyanotic lips, elevated respiratory rate, agitated with altered GCS, tachycardic, and non-measurable blood pressure. There was blood gushing from the wound. It was packed and she got some manual pressure. So she had an IV line, tranexamic acid, some vasopressors given while the transport. So 1 hour after the call to the EMS, she was in the hospital in the Raptor room. There was focused abdominal ultrasound for trauma performed, which showed positive abdomen and negative from the other aspects, and there was just this single wound. So a massive transfusion protocol was initiated. She had some more IV lines and an access to the femoral artery for Riboa if needed. and rapid sequence intubation, and she was acidotic, lactogenic, and had the hemoglobin was a bit low. So if I understand right, I'm supposed to ask some questions during the path from the panelists, right?
Yes, and I'll take over. So we have three panelists joining us. We have Dr. Serna, Dr. Quedetis, and Dr. Ito. So let's start. Anyone else would like to be a panelist, I think we can accommodate that as well. But I'll start with Dr. Quedetis. Thoughts on this patient, Dr. Martha?
Okay, so we have a very unstable patient, and we do not have here in Panama the Raptor hybrid OR. So I will take this patient immediately to the in the operating room and probably do an left side thoracotomy or resuscitative thoracotomy since the blood pressure was not palpable. I will clamp the aorta and then do the laparotomy.
Okay. Do you have Dr. Martha Ribowa capabilities in Panama or no?
No, we do not have.
Dr. Serna, your thoughts?
Yeah, I have a question. What is the systolic blood pressure for this patient?
It was during the transport. It was not non-measurable.
But in the emergency room, when the patient came, what is the systolic blood pressure? It's very important for me because this
It
point,
was 50 over 30, 50 over 30, yeah.
Okay, okay. In my hospital, this patient is an so unstable patient. We said if the patient have a systolic blood pressure under 70, you can fly. And in my mind, is the priority for this patient is start the hemostatic resuscitation, the aorta, with Reboa, and go to the operation room to laparotomy. In this order, first start the hemostatic resuscitation, put Reboa, and perform the laparotomy.
Okay. Dr. Curry?
Yes. So the actually, if a patient still have the pulse, like a palpable pulse, I may try the Reboa to occlude the aorta because our hospital also has the something like a Raptor, so we can use the fluoroscopy to place the catheter. But in this situation, seems like patient's non-palpable pulse, I will go to the resuscitative thoracotomy to clamp the aorta, then do the laparotomy.
Thank you. And I think we have one comment from the audience as well. Dr. Kasim said first resuscitation on the way to the OR, and then clamp the aorta. And Dr. Martha said the same thing, blood before the resuscitation. So I think we have a consensus, thoracotomy, clamping the aorta, and taking the patient to the OR. So what did we do next, Dr. Tolonen?
Yeah, just a reminder that we had an access to femoral artery just to put in the Reboa whenever needed, and we had it ready in place, but she responded to the resuscitation so that, and we're also already in this Raptor room where we can do open surgery in the same bed. There's no need to transfer the patient anywhere. So yeah, it's pretty obvious that you need a laparotomy. So a midline incision was done. This was like 20 minutes later than 13 minutes later than the patient came to the hospital. There was markable hemoperitonema of 3 liters and some bile in the abdomen. There was heavy bleeding from the hypoduodenal ligament, and an additional transverse incision to the right side was made. There was single stab which went through the liver from segment 5, and from the anatomy you could tell that the proper hepatic artery was transected and there was a large hole in the medial side of the portal vein. And at this point in the operating room, there was a trauma surgeon, a liver transplant surgeon, general surgeon, and a vascular surgeon in place. So my next question is what's the best plan to obtain bleeding control? And for the sake of clarity, the patient had the opportunity to fill in the Reboa very quickly, but she didn't need that at that point. With just manual compression, her blood pressure was slightly better, and with the resuscitation, obviously as well.
Okay, thank you. It's great that you had all the specialists available at one time. But we'll start in the opposite order now. Dr. Corey, your thoughts?
Oh, yes. It's a very difficult situation, but first of all, just to do the packing for the parenchymal injury with the river, and then probably do the Pringles maneuver to clamp the hiram. But I don't know there is a injury to the proper hepatic artery and then portal vein, and I hope we can have some control of the bleeding doing the yeah. I'm sorry, I'm doing that Pringles maneuver.
Nigger, nigger, gal, black niggers.
Yeah, thank you. Dr. Tolonen, can you go back to the previous slide and just let's see, have that information there so we can, discuss while we have that information in front of us. Thank you. Next person is going to be Dr. Serna. Like, your thoughts, sir? Okay, while we wait for Dr. Serna, maybe Dr. Marta.
Okay, so I will pack the liver injury inside. If it's bleeding through there, then I think that we can ligate the hepatic artery that is already transected. And since you have the help of the vascular and the transplant surgeon, they might help you suture the portal vein that it might get access through the Pringle maneuver and to get the control. And that's what I will do with this patient.
Okay. Can you hear me?
Yes.
Yes. It's very difficult situation, but I think first is put Reboa in zone 1, packing and resuscitation. When the patient is better, the second step is explore the hole, and if the lesion is in proper hepatic artery, you need to repair. Is the hole is in the branches, you can ligate it, but it's the proper hepatic artery, you need repair. And in the portal vein, if the hole is in maybe in the right branch or left branch, you can ligate. But if the hole is in the portal vein, you need to repair. And I think the better option is to test the patient, control proximal and distal control with I think clamp proximal and distal in the hepatic ileum, and repair the artery in my hospital. But in the Raptor room in Thailand, I think it's a good option. Put the stent in the proper artery and try to repair the portal vein with open repair, hybrid repair, stent in the proper artery, hepatic proper artery, and repair the portal vein with open repair.
Okay, and I think we have some comments from our audience as well, which majority of them are mentioning stenting the artery and then going ahead and repairing the portal vein. Also, Dr. Kasim said ligate the hepatic artery and then, of course, repair the portal vein. Questions for the panelists as well, and also maybe Dr. Tolonen can chime in. Like when we're talking about the first step in these cases is pressure, right? Holding pressure, getting control of that bleeding, manual pressure palpation. Do you guys mobilize the ligaments, the triangular ligaments and everything, or use that to your advantage to hold pressure kind of sandwich that injury between the ligaments and diaphragm and the liver, and how do you do that, Dr. Martha?
I will liberate the falciform ligament, and maybe it depends on how difficult or where the injury is. I'll try to do the manual compression without taking the triangular ligament, and it depends on each situation.
Okay, so Dr. Tolonen, let's see what we did next.
Yep.
Sorry. I have another thing. I think this is the explore these vascular lesions is very difficult, but I think the better option is within the hole and explore from the hole. I think it's better for this patient.
Okay.
Yep. So it's a tricky case. You can't really get off of the portal vein, but gladly it's extrahepatic and the main portal vein, so it's visible there without much mobilization. So what was done, there was proximal and distal clamping of the hepatic hilum with 2 Satinsky clamps, and I'm going to move on to what was done in the index laparotomy. So there was a selective suture for bleeding control from the proper hepatic artery just to cease the bleeding. Then the portal bleeding was controlled with those Satinsky clamps, and the portal vein was reconstructed with the pericardial patch. There was no mention of the flow, measured flow in the operation report. And after that, the hepatic artery was, there was an attempt to put a tube in it just to stent it. But it was so spasmed that it didn't work. So they decided to do a reconstruction with an interposition graft from the left great saphenous vein. The liver was packed. There was not much bleeding, just with flow seal. And the common bile duct was intact, non-injured. And they decided not to do coarctation, which might have made it easier for the repairs, but there were no bleedings from no signs of bleeding or injury in the head of the pancreas or the duodenum. So the hemodynamics with resuscitation and obtaining bleeding control got better. The Pringle was on for about an hour, and but still the liver color looked surprisingly good. The bowel was swollen, but the color started to get better when the blood flow was restored. So they finished up the initial operation with closing the transverse incision, and for the midline they put an open abdomen with Apthera and left 1 drain to the foramen of Winslow. So the bleeding was total bleeding was a little less than 5 liters, but it was a very long index operation for unstable trauma. So now we're in the ICU, the first morning of the surgery. The patient was doing very well. A CT was decided to be done, and there was very vast thrombosis in the portal vein, which went into the superior and inferior mesenteric veins and splenic vein. And the bowel looked like a shock bowel, and it was thought to have venous bowel ischemia. And the liver arteries were open. I have some more images, and which might explain why the liver took so well of 1 hour without blood flow, was that there was a strong left aberrant liver artery, which is present in about 14% of humans. And here you can see the arterial reconstruction, which looks nice in the CT image. So what's the next plan? We have very vast thrombosis in the portal system.
All right, Dr.
And a
Simon.
bad looking bowel.
Okay, but I think it's an acute thrombosis, maybe for two situations. I think first it's very long surgery, very long clamp in position, and in an unstable patient, and use the heparin and others, it's very dangerous. And the second, the patch, and sometimes is propense to thrombosis. I prefer in these cases the primary suture, transverse suture with a polypropylene, maybe 8 zeros or 7 zeros, to prevent that thrombosis. But in this moment, the vein is with a thrombosis. I think the better option is embolectomy and remake the repair. Maybe without patch, maybe an TT anastomosis with maybe 8 zeros, 8-0 polypropylene. But
Just a brief,
thromboemboliectomy.
just a brief comment that in the index operation, the experienced liver and vascular surgeons considered that direct repair for the portal vein was not possible due to the injury.
Okay. Dr. Marta?
This is a very, very bad complication after the initial surgery. And I think this patient benefits from a thrombectomy since this is postoperative day 1, and try to restore the venous flow.
Dr. Corey?
Yes, so I think I also think this patient probably needs the portal vein thrombectomy, and it can be done by transcatheter or just by the surgical. We may be able to access to the portal vein through this somewhere in the mesenteric vein. Maybe we can do do the thrombectomy and thrombolysis through the catheter.
Okay, I think so the general census is thrombectomy. And one of the things, since we have residents and fellows on this call, we talk about when we talk about Pringle maneuver, it was 60 minutes. Was there any off clamp time on that, or was 60 minutes clamped when we did the Pringle maneuver, Dr. Tolonen?
There was no possibility to take the clamp off because it would have bled all the time since there was such injuries in the ligament.
Okay, so I think that's one of the thought processes. I think always better to consider, when you're doing Pringle and these such as complex injuries, it's always difficult because of the bleeding. You can always, gently release it as much as possible. If you're using a clamp, you can use your finger, but 15-20 minutes of Pringle. If you go for longer, always, have that thought process in the back of your mind about a complication like this that can happen for long clamp time. So since we have the census from the panelists, I think we can go ahead and see what Dr. Tolan did.
Yeah, just a brief comment on I understand that philosophy for liver injuries, letting the clamp go for a while, but now that we had the injury in the epidural ligament, if you just let it go, nothing will happen to the liver doesn't gain any blood flow before the reconstructions are done. So it would have just caused more bleeding in this particular case. So obviously back to the OR, the abdomen is already open, so it's an easy decision. The reconstructed artery was fine. The operation started with doing a coarctation, and there was a surprise hole in the IVC. It's a 2-centimeter hole, which did not create a hematoma or bleed. It was just missed in the first surgery, but it was sutured. Only the front wall was injured, and that was that only took like 1 minute. So the proximal portal vein anastomosis was very close to the pancreas. The anastomosis did not look well. It was too narrow, and so it was decided to reconstruct the portal vein. So it was carefully dissected and with some difficulties to obtain proximal control from the vein. Embolectomy was done with the Fogarty catheter, and the reconstruction of the portal vein was done with cadaver iliac artery, which was considered by the chief of our liver surgery to work better in this particular time. It was already in the fridge ready. So then the right hepatic artery was actually found spasmed and transected in the hepatic hilum. It had not bled, but it was also reconstructed inside to the previous arterial reconstruction. Cholecystectomy was done. There was a small amount of bile from the hepatic injury site, which was only drained. Nothing else was done. The bowel got better, and we continued with Apthera with mesh-mediated fascial traction. Some images from the surgery is the embolectomy from the portal vein. And here is the cadaver iliac artery, which was used for the reconstruction. And here's the arterial reconstruction. And we used the mesh-mediated fascial traction system. And these are just this is when the patient got in. So the liver values are here. And you can see that there's only a mild elevation of the liver enzymes, and it dissolved very quickly and normalized within a week. Also, the bilirubin took a hit only in the first day and normalized very quickly after that. And we have some explanations for this. I think we can discuss them later. Other than that, the patient did pretty well. And we only did two mesh tightenings, and everything looked great. The delayed primary fascial closure was achieved within a week, and Doppler ultrasound for the liver blood flow showed great, and with no problems. The patient got to the regular ward from the ICU on day 9. There were some psychiatric issues with the patient, and a small amount of bile came from the drain. It ceased spontaneous, and the drain was removed, and the patient went home on day 14. So I have some points for discussion. Do you want me to show them or just discuss first?
No, I think we can go ahead and show them, and we can discuss while we are points so that so people can look at these points.
Yeah, just I think these would be some points for discussion in this case, in my opinion. Feel free to come up with other points of discussion as well.
So I think we'll open the stage, Dr. Martha.
Yeah, so I just want to say that as Dr. Tolonen already said, the cauterization of the duodenum will make things a little easier for the index laparotomy. And also, well, that's our nightmare, like missing injuries. And I guess that's something that we can prevent by doing all these maneuvers that are basic stuff doing in trauma laparotomy. That's the only thing that I want to say. And the other thing about the reconstruction of the hepatic artery after having an CT, angio CT that show a very good flow. I don't think that that's something that at least here we will take again, or do again.
So we have a question from the audience. How much blood loss, how much blood products did you give in the first operation?
She could have changed pretty much all her blood. It was around 5 liters. I don't have the exact numbers at my hand now, but I think it's fair to say that the same amount she had before the stabbing.
Okay. Dr. Corey?
Yeah, first of all, yes, thank you so much for this, great case. It was, really bad, hepatic, vascular injury case, but, you successfully saved the patient. That's wonderful. And so in terms of at the first operation, whether or not, we should do the reconstruction of the vessel or not is, I think, something debatable. And personally, I've never done, but if we see the really bad hepatic artery injury, we may be able to do maybe shunting just to temporize the blood flow. And something like I can think about. And also in terms of the IVC injury was missed at the first operation, but at the first operation, I think packing was, first thing to do, and it may be at least if bleeding was controlled with the packing, I think you can re-evaluate in the second root surgery. So yeah, that's it. Yeah, thank you so much for the great case.
Dr. Cern.
Okay. First, congratulations for this case, because the mortality for this injury is very high, and if the patient is alive, it's congratulations for you and your team. The first question, the need to reconstruction the hepatic artery. I think if you can, it's better reconstruct. If you can't, because it's ligated, but if you can reconstruct. At this point, I have a question to Mati. If you have a Raptor room, why didn't think to put stent in the hepatic artery? Because it's more easy, and maybe for this way the index laparotomy it's less time.
It was fully transected, so stent was not considered an option. Shunting was tried, but this vessel was so spasmed that they couldn't get a proper shunt in. That's why it was decided to do the reconstruction.
Okay, it's difficult, but if the artery is transected, but in the hybrid procedure, maybe you can't pass the wire through the transection and put the stent. It's only a thing for my don't worry. The second, the long index laparotomy, I think you want to use less time, but the lesions are too severe. One always does the best. It's very difficult to repair these lesions, and it's impossible use less than an hour. It's very difficult to reconstruct an artery and vein. Is very difficult and take a time, this reconstruction. That the IBC misses lesson. I think it's not normal, but when the patient is so unstable and so many severe injuries, and the IBC maybe stop bleed with packing, and I it's not a big deal if in the second laparotomy you can repair this lesion. And congratulations, and it's very good case.
Thank you. Yeah, I think the consensus is that the hepatic artery is completely transected. It should be reconstructed. There's not much data, but the liver surely will take a hit if it's not done. And I think there was not much, no ways to avoid the very long index laparotomy, despite the patient was so unstable, but she was young, luckily. The missed IVC injury is obviously a bit shameful. Just got lucky that it didn't turn out into a massive problem with this patient. And I personally think that the coagulation should have been done in the first operation, which would have revealed the hole, but it would have also caused some more bleeding. So I think just simple luck of missing that injury in the first laparotomy. There are a variety of portal vein reconstruction techniques. I'm not sure if, well, I am sure that there's no good data to show that which would be better in a trauma situation. But what I do think is that the strong left aberrant liver artery kind of saved the patient's liver from massive complications. So that's why everything went so smoothly, because the liver was not without blood flow even during the index operation. And I think that's the key in this patient, is she got very lucky to be in the 14% who has this aberrant left liver artery. And also the patient was 19, and she has very good resources to recover quickly from even such a severe injury. But I thank you very much for the discussion and the opportunity to present the case. Thank you.
Thank you, Dr. Tolonen.
Dr. Tolonen, can I just say, I don't think that it's shameful at all that you missed the IVC injury. You know, I've seen this before when patients have significant bleeding, life-threatening bleeding from other things. They get so hypotensive that the IVC clots it doesn't bleed and it clots and it can get missed, and that it happens. It's okay. The important thing is that it was identified and fixed eventually. I wouldn't be ashamed about that at all.
Okay, thank you so much, Mel.
Can you kindly unshare Dr. Tolonen so that Dr. Lauren can? All right. Thank you, Dr. Badami. Dr. Schorl.
Can you all
All
see?
right. All right, yes, we can see your presentation, Dr. Moore. So the next presentation is by Dr. Lauren Moore from University of Buffalo.
Hi, everyone. I'm Lauren. I'm a PGY2 surgery resident at Buffalo, and I'm going to talk about complex pelvic fracture. So pre-arrival, this was a 29-year-old male. He was presenting as a P1 status post MVC versus MCC. He was ejected from his motorcycle and thrown approximately 50 feet. When EMS arrived to scene, he had agonal breathing, pulse was detected. On the way to the hospital, he developed PEA arrest. He underwent 5 to 6 minutes of CPR before ROSC was obtained. You can see his vitals there. He also had bilateral needle decompression. So arrival to the trauma bay was about 13 minutes after EMS presented on scene. Again, his vitals are there. He had a GCS of 3. He was intubated upon arrival to the trauma bay. Bilateral open chest tubes were placed, and a pelvic binder was also placed in the ED. Shortly after, he developed bradycardia into the 30s with loss of pulses. CPR was initiated for 10 minutes with achievement of ROSC. While in the trauma bay, he received 2 whole blood, 5 PRBC, 5 FFP, and then TXA. On secondary survey, he was noted to have right-sided chest wall crepitus, an open wound on the right lower extremity concerning for open fracture and significant rectal bleeding on DRE. And you can see his pelvic right there. So my first question is, next step, you have a patient who's hemodynamically unstable, has this X-ray. What do you recommend next?
So first, can I ask you, Lauren, to just go back to 2 slides, actually? Okay, thanks. So I would like to ask the panelists their thoughts about management. Oh, one slide.
What do you want to say?
Yeah, about how you would manage this patient when they first come to the ED, and if you know, if you would do anything differently here in your management process when the patient comes in unstable and then pulseless. Dr. Kunitz?
So this is another very sick patient, and we have to act very quickly. The first sign is a bilateral chest tube, or even hold only with the finger chest tube, or open in the chest. And then a lot of blood, as you did. We did not have whole blood, but we can use non-type specific non-cross or not much non-cross blood PRBCs. And then these patients, it depends. If he lost pulses, we will do an ED thoracotomy instead of having to do CPR.
Dr. Chiari?
Yeah, so I actually agree with the Martha. So this patient lost the pulse in the ED. Probably I will go ahead to do the ED thoracotomy at that point and then clamp the aorta. And then also actually I have one question. How was the vital signs after patient got the ROSC? Patient got a good blood pressure after that?
He remained hemodynamically unstable, but slight improvement.
Thank you.
Dr. Sterner, any thoughts?
Yeah. I think the better for this patient is a CT scan, but the patient is very unstable after the massive transfusion. The patient is not responder. And I think in this moment, the better for this patient is put the Rivoa in someone and go to the operation room.
Okay, thanks. Dr. Moore, can you go forward again? Sorry, let's just review this next slide, or the previous slide. Okay. So you have a concerning open right lower extremity wound, rectal bleeding, obvious pelvic fracture, and chest wall crepitus. So, and is the patient still unstable at this point?
Well, so he was stable enough that we ended up going to the scanner.
Okay, okay, go ahead.
So we scanned him. There's a lot of injuries, but essentially he had this vertical shear pelvic fracture with active extrav from the right iliac artery. He had a very large extraperitoneal hematoma. And then also he had a retroperitoneal hematoma, along with external iliac artery dissection. And then you can see the various other injuries on the other side. I have the scans. Just briefly, you can see the hematoma. And then just to appreciate the occlusion of the right lower extremity, lack of flow. So my next question then would be, having the information you have now, the next steps, angio versus packing versus X-fix with ortho or ICU to resuscitate the patient more.
What do you think, Dr. Cerna?
Yes. I think the CT scan very good information, but in this patient in particular, I think it's very dangerous to go to the CT scan with 70 systolic blood pressure. But with these findings, I think the better option is an hybrid procedure. The angio and the operation room is not excluded. I think go to the operation room, packing the pelvis, drain to hematoma, and embolization to the hypogastric artery with coils. I think this is the better option for this patient because this patient is very unstable, and you need to do the better in the less than time, and I think it's the better option. Laparotomy, drain the hematoma, packing the pelvis, and embolization the hypogastric artery.
Thank you, Dr. Cerna. Dr. Carey?
Yeah, so I think I also think this patient will, benefit from the hybrid operating room. And if patient still hemodynamically unstable, we may be able to try the Reboa in the Zone 3 and for the transferring the patient to the operating room from the ED just to the stabilize. And then I think we may be able to do the pelvic packing first and then do the angio in the hybrid OR. And if we do the angio, we may be able to do TAE for the pelvic bleeding, and also we may be able to evaluate the vessels in the lower extremity and may be able to do some stenting for the reconstruction.
Thank you, Dr. Carey. And Dr. Kilditis?
So unfortunately, we do not have right now in use the hybrid room. So we will have to explore everything and make sure that we control the bleeding first with packing or future repair if it's anything active extravasation, we might end up ligating the both of hypogastric arteries bilaterally and use some type of fixation for the pelvic structure. It might be even a sheet around the patient. Or in the case that the orthopedic surgeons are available, placing a zip clamp. And then use of packing to try to control all the venous bleeding that it might be in the pelvis. And then the repair for the popliteal artery.
There's a question in the chat, Dr. Moore, from Dr. Utrecht, who wants to know if there was a head CT done.
Yes, they did scan his head as well.
Did he have any injuries in the head?
No.
And I'm curious, for the panelists, there was some, I think Dr. Moore mentioned some concern about a possible rectal injury with some rectal bleeding on the PR exam. Would anyone address that at this point?
Yes, it's possible this patient has a very big rectal injury, but in this moment, the priority for this patient is bleeding control, and I think it's an for the next step. The first step is put Rivoa in zone 1. The next step, the first step is it's continue the hemostatic resuscitation and more blood wall, more platelets, more plasma. And the second step is put Rivoa in zone 1. The third step is laparotomy and packing. And the first step is embolization, the hypogastric artery. In this moment, when the patient is better, you can decide if the patient needs to rectosigmoidoscopy or packing through the anus in the rectum, and I don't know. But in this moment, the priority for this patient is the resuscitation, the resuscitation and the bleeding control.
Okay, thank you, Dr. Serna. I think we have an agreement from the panelists on that. Dr. Moore, why don't you continue?
Okay. So this patient did go for angio. At this time, he had now gotten 12 of PRBC, 12 of FFP, and then 1 SPP. His vital signs, you can see he was hemodynamically unstable. He's on levo at 30. He had coil embo of the right internal iliac artery with a 5 millimeter and 8 millimeter coil. While he was in the angio suite, he also got another 6 of PRBC, 6 of FFP, and then 1 SPP. And I guess of note too, during this procedure, they did see a total occlusion of the popliteal artery on the right with no reconstitution, but the patient was too unstable to do anything about it at that time. So the patient was taken back to the ICU. And in 2.5 hours post-angio, he had worsening hemodynamics. He had increasing levo and vaso requirements. He got an additional 6 of PRBC, 6 of FFP, and 1 SPP. And these were his vitals. So my question again now for you all is, next step, OR for preperitoneal packing. Do you do an X-lap to rule out viscous injury, or intraperitoneal pelvic packing?
Dr. Carey, what do you think? Preperitoneal packing or exploratory laparotomy?
So I have a question. Did you do any like a bedside ultrasound, like a fast?
I do not recall seeing a fast noted by the ED.
So, okay. So before, I jump into the next procedure, probably I need a little bit more information whether or not, in the ultrasound, patient have any intraperitoneal fluid or other source of bleeding.
Dr. Moore, was there any evidence of intra-abdominal injury on his CT?
He had the retroperitoneal hematoma.
Okay, thank you. Dr. Kioretis.
I think this patient benefits from the exploratory laparotomy just after the coil placement to make sure that all the air that you have inside the and the belly in the city, you need to look out for that other associated injuries.
Dr. Serna, do you agree? Laparotomy, or would you do prepared nail packing?
Yes, I performed the laparotomy in the last step. I think it's very common in this patient after massive bleeding from the pelvis and after embolization to develop abdominal compartment syndrome. And I think this patient maybe had this, but it's very important to perform laparotomy, drain the hematoma, and maybe to the abdominal compartment syndrome. I think so.
Great point. All right, Dr. Moore, tell us what you did.
So he went for preperitoneal pelvic packing. He also had a suprapubic catheter placed by urology and then an external X-fix of the pelvis with ortho. There was significant venous hemorrhage in the preperitoneal space, and after X-fix, ortho actually placed the pelvic binder in addition, and there was marked improvement in pelvic alignment and hemodynamics. This is a picture actually post-op of the X-fix and the binder, and you can see the suprapubic catheter coming. So 9 hours post preperitoneal packing and X-fix, this patient developed increasing peak airway pressures and pressure requirements, worsening hemodynamics, and a tense abdomen. There was concern for abdominal compartment syndrome. So the decision was made to do a bedside decompression. Upon opening the abdomen, there was frank necrotic bowel. So they immediately went to the OR for an X-lap. Necrotic bowel was noted from the distal ileum to the proximal sigmoid colon. So subtotal colectomy with resection of about 30 centimeters of distal ileum was done. And then there was also a soft right retroperitoneal hematoma noted and approximately 500 cc's of old hematoma found within the abdomen. The patient was left in discontinuity and temporary abdominal closure. 14 hours after that, he returned to the OR again. He was having severe acidosis, hyperkalemia. He had this known right lower extremity ischemia, and the thought that could potentially be contributing to his hyperkalemia. He had dusky bowel with without frank necrosis at the time, and the remaining sigmoid appeared healthy. But they did do a right lower extremity guillotine, AKA, in hopes to improve his hyperkalemia and acidosis. 32 hours after that, the patient went into cardiac arrest. CPR was initiated for 12 minutes with achievement of ROSC. This patient had continued to have persistent hyperkalemia up to 8.1. And this was despite dialysis. And you can see his myoglobin was very high, LDH, and then his haptoglobin was less than 8. But 24 hours post cardiac arrest, he had been weaned from 4 pressors to 2. His FiO2 was now at 50 from 100, and his hyperkalemia went from greater than 8 to less than 6. There was plans for removal of packing and creating an endoleostomy and definitive closure. But my question for you all would be, when would you go back in a patient like this, and is this optimized enough and as optimized as you're going to get?
Dr. Kiretis, how do you decide to go back, when to go back?
I would like to know the pH, the crack, the status of coagulation, and the temperature of this patient. But as soon as things kind of start improving, I think that we need to at least do the ileostomy and for the removal of the packing, and I would not consider definitive closure with all these issues going on still.
Dr. Serna? Will we wait for him, Dr. Chiari?
So I agree with Dr. Mercer. So once patient acidosis was corrected, coagulopathy was corrected, and blood temperature was okay, we may be able to go back to the operating room to remove our packing first, and then making sure the hemostasis. So I think I will not close the abdomen at the second operation, maybe wait until all edema of the bowel is going away before the close of the abdomen.
All right, why don't you go ahead, Lauren?
What is the age for this patient?
29.
29. Okay. I think why do you think in the end ileostomy? Why not an ileorectal anastomosis if the patient is very young and in this moment the patient is better? And what do you think about the try to the anastomosis, to the rest of the reconstruction to the gastrointestinal tract?
I mean, I guess it would not be unreasonable, although he had been so hemodynamically unstable and on pressors still. So I don't know how the anastomosis would necessarily.
But in this moment the patient is better or not? It's
not entirely.
Looks like still on 2 pressors. Weaned from 4 to 2.
Without vasopressors, and I don't know. It's only for I think for the discussion, but it's maybe the better for the patient is the ileostomy. But I think about the discussion. It's very important to think about the reconstruction, because in my hospital we think in the patient in this option to the reconstruction. Maybe wait 2 or 3 days more. The patient is better, and try to do the anastomosis.
May I answer? I won't consider this anastomosis on this type of patient. She already had at least 3 cardiac arrests. So even if she's still alive, she is very sick at this moment. And so we should aim to do the less possible for her to keep her alive.
Thank you, Dr. Quilletes. There's a comment from Dr. Gyo in the chat as well, who says similar. He's concerned that the patient has been very sick, large transfusion, and it would be risky to do it. He thinks it to be risky to do ileorectal anastomosis. Okay, Dr. Moore, why don't you go on?
So return to the OR 24 hours after cardiac arrest, 48 hours post-op XLAP, right lower extremity AKA and temporary closure. Unfortunately, it was noted he had ischemic sigmoid colon and up to the proximal rectum. There was also evidence of preperitoneal rectal perforation with pelvis in the stool contaminating the open pelvic fracture when they changed the packing out. And then when they took the binder down to do these packing, his left lower extremity became mottled. His potassium actually went up close to 8 again from around 6. And he was increasingly more hemodynamically unstable during this procedure. So the decision was made to do a left guillotine, AKA, as well as LAR, washout of the preperitoneal space, packing replacement, and temporary abdominal closure. And then 24 hours post-return to the OR, he was transitioned to comfort care and then was terminally extubated. I think somebody had asked earlier if we had done a head CT, and one of the things that I didn't mention was initially after his angio, he was responding to commands, and so he was intact, and I think that's part of why his family felt very strongly about doing what they could. But after that last operation, they decided to transition to comfort. And this is just a timeline because so many things happened in such a short amount of time to give you a better idea of the events that took place. And that's it. I don't know if anyone has any other thoughts or comments.
Dr. Sterna, any final thoughts about this case?
What happened with the popliteal artery lesion? Sorry.
What happened?
Yes, do reconstruct the popliteal artery or what?
He had a right guillotine, aka.
Okay. Okay. I think that in patient so critically ill and unstable and unresponsive to resuscitation, the patient needs to do everything in the first time. This case is a very good case, congratulations. But for the future case, I think it's better to do everything in the first time. Hemostatic resuscitation, REVOA, preperitoneal packing, embolization, and laparotomy. Because if you perform everything in the first time, I think it's my think the patient doing better. I think.
Dr. Kiretis, any thoughts?
Yeah, I think this patient, if you have the possibility to do the angioembolization before doing the laparotomy, that's a very good thing to have. But I think the patient was already in a state that it was very, very sick. So I will not be only considering that the artery injury as a cause of all the shock that patient was having. And also considering the repair of the popliteal artery, or at least something to try to do something while you keep on resuscitating the patient. So that's the only thing that I can would do different, like doing the exploratory laparotomy after the angioembolization, immediately after the angioembolization, and trying to repair the popliteal artery in the same at the same initial operation.
And Dr. Chiari?
Yeah, so first, thank you so much for this, really difficult case. Yeah, so what my think is that if we know the popliteal artery was occluded at the initial evaluation, so we should do something for that. If we know this patient is too sick and if we cannot do any reperfusion to the popliteal artery, it is very predictable, that ram going to dead and will cause the rhabdomyolysis or hyperkalemia. And if we address that injury a little bit earlier, we may be able to avoid the second cardiac arrest due to the hyperkalemia. But and also I will do that laparotomy after the angioembolization for the pelvis at the initial operation. That's it. Thank you so much.
Dr. Moore, there's some just quick questions in the chat. I realize we're almost over. Did you perform or consider fasciotomy for the ischemia of the right leg initially? And why do you think their patient had dead bowel? Was there possibly an SMA occlusion or thrombosis, or was it compartment syndrome?
So in regard to the fasciotomy, I was not there for some of the ICU discussions, but I did not see any note of talks of a fasciotomy. And then in regard to the ischemic bowel, I mean, it potentially, but also, he was maxed out on pressors, which could have also played a role.
Thank you very much for your presentation, Dr. Moore. This is a really challenging case that I think highlights the difficulty of managing these really severely multiply injured patients. It can be quite challenging.
Thank you.
All right, thank you very much, all presenters and moderators and panelists. These were tough cases, very interesting discussions. I'm going to thank our audience and for their comments, and we're going to close with Dr. Badami with an announcement for the PTS. Thank you, Rebecca. Thank you, Abbas.
Thank you, Dr. Pascal. So just wanted to make a quick pitch for our PTS Trauma and Acute Care Surgery course starting October 18th. It'll be similar format, extremely important, and I think beneficial for our residents and trainees. We'll be discussing lectures from trauma and acute care surgery, like preperitoneal packing, how to do it, pelvic traumas. You can reach out to Dr. Marcus Hoffman. I'm going to send his email in this chat. So if you have any cases to present, or if you have any how to do tips, please reach out to him. The first topic is acute cholecystitis in October, and November is pelvic trauma. Thank you, Dr. Pascal.
Thank you. Have a good week.